Hello students, welcome to the Pediatrics Pointers, your ultimate revision series in the Pediatrics. And today the topic is from the CNS disorders, that is acute bacterial meningitis. Now first what you should remember in this topic is the causative organisms, particularly in the different scenarios. What are particularly the causative organism? So if there is defect of the complement system, maybe C5 to C8 deficiency, the answer is meningococcus. And if it is C3b deficiency, the answer is pneumococcus. If it is a CSF shunt which is causing meningitis, it is a prosthetic material, and whenever there is a prosthetic material, the answer is staph epidermidis coagulase negative staphylococci. In meningomyelocele, if there is meningitis, the cause is basically staph aureus. In T lymphocyte defect, the causative organism of meningitis is Listeria monocytogenes. If there is splenic dysfunction or asplenia, hyposplenia, basically the incidence of encapsulated organism is increased, which includes pneumococci, H. influenzae, meningococci, and out of the three, the most common is the pneumococci. Then you should remember how a child of meningitis can present. He can present with three things. Either there can be signs of meningeal irritation, either there can be signs of increased intracranial pressure, or with some complication. Now, signs of meningeal irritation includes nuchal rigidity, Kerning sign, Rudzinski sign. Sign of increased intracranial pressure includes headache, emesis, bulging fontanelle, and remember oculomotor or abductor nerve paralysis. So which cranial nerves are affected in increased intracranial pressure? Your answer is oculomotor or abductor nerve. They can present with hypertension, bradycardia, bradypnea, and this becomes is your Cushing's triad. This is your particularly Cushing's triad, and there can be papilledema. So these are the signs of increased intracranial pressure. The child of meningitis can present to you with complication. The most common complication is seizures. It can be syndrome of inappropriate antidiuretic hormone, subdural effusion, subdural empyema, and stroke. You can all remember they all start with the letter S, and there can be ventriculitis. So child can basically present with any one of these features in the meningitis. To make a diagnosis of neurological squeal, the most common long-term problem can be sensory neural hearing loss, and there can also be hydrocephalus. If you want to make the diagnosis, you basically need to go for the CSF examination. And in the CSF examination, we are mainly looking for the number of cells, what is the sugar level, what is the protein level. So we are talking here diagnosis in children, not in neonates. In children, normally the cells are less than 5, the protein is 20 to 45 milligram per deciliter, and the glucose is more than 75% of serum glucose. In acute bacterial meningitis, the cell count rises very much. It can be 100 to 10,000, and it is usually neutrophils. The protein is 100 to 500, and the sugar is less than 50% of serum glucose. Partially treated bacterial meningitis, the cell count can be 5 to 10,000, but instead of neutrophils, now this is usually lymphocytes. Protein count is still high, 100 to 500, and the glucose can be normal or decreased. Viral meningitis cells are increased, not that much. It can be 10 to 1000 or 10 to 100, and they are usually lymphocytes. Protein is mildly elevated, 50 to 100, but CSF sugar is something which is normal is there. These three pictures you should remember: acute bacterial meningitis, partially treated bacterial meningitis, and viral meningitis. Now treatment, particularly you should remember the antibiotic therapy. The empirical therapy which we are using in India is third generation cephalosporin plus vancomycin. So if you consider Streptococcus pneumoniae, your first line is third generation cephalosporin and penicillin. But if it is resistant, you are giving vancomycin. Remember, the duration is 10 to 14 days. But in this case, no chemoprophylaxis is required. H. influenzae, you are giving third generation cephalosporin. More important to remember, 7 to 10 days. There is chemoprophylaxis required. Rifampin is given for 4 days. Meningococcus third generation cephalosporin, 5 to 7 days. Chemoprophylaxis can be rifampin for 2 days or single dose of ciprofloxacin or ceftriaxone, again a single dose, less than 15 years 125 milligram, more than 15 years 250 milligram. So if you basically see here, Streptococcus pneumoniae third generation cephalosporin, H. influenzae third generation cephalosporin, Meningococcus third generation cephalosporin, and if Streptococcus pneumoniae is resistant, then vancomycin. So in India, these are the three major causes. Therefore, what is the empirical therapy in India? Third generation cephalosporin plus vancomycin. So this is the revision of the topic of acute bacterial meningitis. Do subscribe to the channel. Thanks for watching.